Hello everybody. Over the next half an hour we will talk about how to deliver the impacts of the prostate cancer pathway. Here are my disclosures. We know that there are four major benefits of the prostate cancer pathway. Number one, it reduces the number of patients undergoing a biopsy, and it reduces the diagnosis of indolent cancers, and this is related to the rule out ability of MRI. But we also know that for some patients it improves the precision of risk stratification, and it also increases the detection of clinically significant cancers, and this speaks to the rule-in ability of MRI. So if you look at this randomized study in Canada, where men were randomized to a systematic biopsy versus an MRI targeted biopsy for positive MRI scans, you'll notice on the right hand side that 37% of men avoided a biopsy, and there was an absolute 12% difference between the detection of clinically insignificant cancers, which was lower in the MRI targeted biopsy. You'll also notice that there was only a minor difference in the detection of clinically significant disease of about 5%. And this merely confirms what we know from the Cochrane analysis, which was published last year, where we can see that men undergoing a systematic biopsy had a higher clinically insignificant detection rate. So you can see it's about a 10% difference between the MRI pathway versus the systematic pathway. And remember, the MRI pathway is no biopsies for negative scans and targeted biopsies alone for a systematic biopsy, and in this analysis 33% of men avoided a biopsy. So in practice this means that if you have an outpatient population where there are 3 men with clinically significant cancers out of 10, if you did a systematic biopsy you would miss 111, and all 700 men with either benign disease or insignificant cancers would need a biopsy, so they would be exposed to unnecessary biopsies and the burdens of biopsy procedures. On the other hand, if you did an MRI approach where you didn't biopsy men with a negative scan and you only biopsied men with a positive scan, you would miss 84 cancers, and in fact you would only need to biopsy 28 men to confirm the absence of clinically significant cancers, and so you would spare 672 men from a biopsy. So MRI makes quite an impact. Now when you look at this data, you'll see that the higher the clinical suspicion of clinically significant disease, the greater is the positivity rate of prostate cancer. There's another way of looking at this. By adding up all these figures, you can work out that 64% of men with a positive MRI, i.e. Pyrites 3 to 5, have no cancer or insignificant cancer. And so in the literature it varies between 30 to 50% of biopsy naive men with a positive MRI have a negative histology or insignificant cancers, and there are other issues. There are multiple quality issues in MRI. There's a steep learning curve in MRI. The performance of radiologists in single centers versus larger centers varies quite a lot. About 50% of men don't get benefit from the contrast medium, and we know it's time intensive to review, report, and then to contour prostates and the lesions, particularly when this is unfunded activity. So if you're going to deliver MRI in a consistent way, we're going to have to think about a number of things, and the first question is who benefits from the use of an MRI. If you look at the EAU guidelines say the people who benefit are those with a slightly elevated PSA and a negative DRE. That's it. Interesting. But that's not what happens in practice. In practice, we take men who are symptomatic or asymptomatic with an elevated PSA and a negative DRE. But it's true that the benefit in people with a positive DRE is not as well shown as you might imagine. Other people that we might biopsy in an outpatient urological center are patients who have an elevated risk and have had a prior negative biopsy or have had an non-explanatory systematic biopsy, or patients who are undergoing safety net monitoring but the PSA is still going up and the safety net monitoring is being done after a prior negative biopsy and you did a prior negative MRI, or after a positive MRI and a negative biopsy. And then of course there's the programmatic use of biopsies and these are patients who are on active surveillance. So if you look at this man with an elevated PSA and a positive DRE, I'm not sure there's any value in giving contrast medium in this particular guy, because everything that we need can be diagnosed without a comprehensive approach. And in fact, there's only one paper that I've actually seen that's looked at this in any great detail, and this is that paper. You can see that the benefit shown here in blue is actually in men with an elevated PSA and a normal DRE. They're the people who benefit the most. There is some benefit up to 20% of patients in whom there is a PSA that is less than 10, but a DRE is positive. And there certainly does not seem to be very many men with a very elevated PSA and a positive DRE benefiting. So let's take a case-based approach and look at a man with a PSA of less than 10 and a positive DRE. Now, what would you do about this? Should he have a systematic biopsy? Remember, this is still standard of care in America and Germany and some parts of Europe. Would you do an MRI? Because that's what we would do in the UK. Do you need to look at the guidelines, or would you discharge the patient to the GP? Well, it turns out if you look at the EAU guidelines, there's no specific recommendations on this patient, right? And if you want to do a biopsy, you're fine to do it. Not a problem. Okay, so we did an MRI because we practiced in the UK, and you'll see that although the DRE is abnormal on the right-hand side, the major abnormality is on the left-hand side because he's got glandular atrophy. So this is in fact a Pyrites 2 case. So, what would you advise in terms of biopsy now? Yeah, look at his PSA density. It's 0.1. So would you do a systematic biopsy? Would you go with the MRI? Because the MRI is negative. Do you want to know about the yields of clinically significant cancers if you were to do a systematic biopsy? Or do you want to look at the EAU guidelines about what to do? Well, if you were to do a systematic biopsy, 3/4 of these men would have a negative scan, right? 3 out of 4. Problem. If you were to do a systematic biopsy, you would overdiagnose 18 men with indolent cancer, so you would expose them to long-term active surveillance. But you would diagnose 8 men with clinically significant cancers. In other words, you would have to biopsy 8 out of 100 negative men to diagnose clinically significant cancer. That's 1 in 12 to 13, roughly. On the other hand, if you decided not to do a biopsy, then you would not diagnose these clinically significant cancers, but you would also miss 3 potentially deadly cancers. And there's the issue. So what do the guidelines say? The guidelines say that you shouldn't biopsy these men. Okay, you should undertake an MDT review, risk profile these men, and then have a safety net of monitoring. So how do you risk profile these men? Well, what you do is you do a PSA density. And if the PSA density is greater than 0.2, there's more than a 10% chance of clinically significant cancer, and you should biopsy those men. And if you look at the EAU guidelines say almost the same thing. When an MRI is negative, i.e. PI-RADS less than 2, and clinical suspicion is low, in other words a low PSA density, omit the biopsy using shared decision making. Okay, so this is somebody who looks apparently similar. You can see again a low PSA, DRE is positive, but in this particular instance you see you've got a PI-RADS 5 lesion. Okay, now would you do a systematic biopsy? Would you do a targeted biopsy alone? Would you do a systematic plus a targeted biopsy, or a regional directed targeted biopsy, or do you want to know what the guidelines say? Well, if you look at the guidelines say you should do a targeted biopsy plus a systematic biopsy. That's what it says in biopsy naive men. Right? In people who've had a previous negative biopsy, just do a targeted biopsy. Okay. So what's the trade-off of doing targeted biopsies alone through this lesion versus targeted plus systematic? Well, if you did a targeted biopsy alone, you would diagnose 39 cancers. If you did a systematic biopsy also, you would diagnose 5 more clinically significant cancers. In other words, you take it up to 44. But if you did a targeted biopsy alone, you would diagnose 16 indolent cancers. If you did a targeted plus a systematic, you would detect 4 more indolent cancers. So this is the crux of the issue. The crux of the issue is that for every man that you diagnose with clinically significant cancers using a combined approach, you would diagnose 1 man with a clinically insignificant cancer, who would of course not gain any benefit. So there's your balance. 1 man gets a benefit, 1 man does not get benefit. And there's the issue. So why is it that we are missing clinically significant cancers when we are doing targeted biopsies? It turns out a lot of these cancers are due to targeting errors. And in fact, if you were to biopsy clinically, if you were to biopsy normal sextants that are away from the MRI targeted lesion, you would find that you do not alter the risk stratification in the majority of patients. In fact, you find that majority of lesions tend to be around the lesion that you saw on the MRI. And we now know that these regional targeted biopsies, also called focal saturation biopsies, increase the yield of significant cancers without affecting the rates of overdiagnosis. So it may be that we need a few biopsies through larger lesions, but more biopsies through diffuse lesions or small lesions, heterogeneous lesions or Pyrites 3 lesions, or even in larger glands or anterior lesions. And you'll find that the Pyrites guideline is consistent with that approach. The Pyrites approach is do targeted plus systematic to keep in line with the EAU guidelines, but as an option, you still have the option of doing focal saturation or regional targeted biopsies. And that's what this man had, and we found a Gleason 9 cancer. So we need to deal with Pyrites 3 cases. Pyrites 3 cases in a mixed population occurs surprisingly often, about 15–16% of cases. And it turns out that about 16, 17, 18, 20% of these patients, i.e. up to 1 in 5, have clinically significant cancer there. Okay, so this is not something that occurs in isolation. So people say it occurs in a very few cases. Well, no, it's not true. In a mixed outpatient population, it occurs in up to, on average, in 16% of cases, but you can see what the confidence interval is. So how do we deal with indeterminate cases? Well, the first thing to do is ask a friend. Get them to check the quality of your scans, make sure it's Pyrites compliant. Did you give or did you not give contrast? Do ADC values, and that can be useful. The other thing you could do is look at the PSA density, or even AI may have a role. So here's a typical Pyrites 3 case. You can see the PSA density is raised. So this patient should get a biopsy anyway. And if you do contrast enhancement, you can see that this is in fact a 3+1. So this is in fact a Pyrites 4 because of the contrast enhancement. But if you were doing biparametric MRI, you would have to call this Pyrites 3. And the PSA density is obviously helpful because this patient had a very raised PSA density, so he was going to get a biopsy anyway. But the PSA density can be useful to decide who to biopsy, who not to biopsy in Pyrites 3 cases. Or you can ask the AI system. And in this particular instance, the AI didn't spot the lesion. So we have a problem. The AI is not validated for this purpose at this time, but it may be in the future. Just think about that. The other thing you can do is ask the MDT what to do, and there you have to decide on a clinical priority review. What is a clinical priority review? Well, not all men are the same. There are men who are biopsy averse. In other words, low-risk men or men in the screening setting where the prevalence of clinically significant cancers is low, so you need a higher threshold to biopsy these men. And for these men, you want to minimize overdiagnosis. On the other hand, you have men who are cancer averse. These are men who have had a negative biopsy before. There's a strong family history, or there's a persistent clinical suspicion. For these men are petrified of having cancer, so they want you to detect their clinically significant cancer, so they are less concerned about false positives. And of course, the way you read these cases will also be different. So in a biopsy-naive men with a regular risk, you want to detect all deadly cancers, so your sensitivity has to be adjusted to the clinical risk. On the other hand, you want to minimize overdiagnosis, so you should have more specificity. However, in a repeat biopsy setting, of course, the priorities are different because these people have come back, right? So you do not want to miss their clinically significant cancer. You want to maximize their sensitivity. In other words, they're going to be more tolerant of false positives. And of course, you need to read the blind spots, as all of us are aware. So here's a man who's 30 years of age. He's clearly got LUTs, and we did an MRI scan. You do not want to call this case, because this is prostatitis today, tomorrow, and day after. Right? Don't biopsy it, because actually the clinical history tells you that this patient should not be called. So the safety net is important. Now, what safety net should you use? Well, if you look at the NICE guidelines in 2019, they say that you should discharge men to primary care when the level of suspicion is low. In other words, when the PSA density is low, and they use a threshold of 0.15, and you give the GP a level of PSA at which to send the patient back to you, and you set the PSA density at 0.15, and here's a patient, just like that. So this man has a negative scan. The AI has a false positive. Now, you look at his PSA density. Its PSA density is low, at 0.07, which is shown at the bottom here. He has a large gland, so you would say to the GP, don't send the patient back until the PSA is 12 nanograms per ml. So you would have to give them an instruction about when to return. So if the GP is looking after the low-risk man, what is the urologist looking after? Well, he's looking after these people who have a positive lesion, but you haven't got a satisfactory explanation on a biopsy. Or you have a patient who has a PI-RADS 3 case and an elevated PSA, and the patient doesn't want a biopsy. Okay, because remember, there's about a 1 in 5 chance of these people having clinically significant cancers. So this is what the urologist will be looking after. If you follow these guidelines, it turns out that over the next couple of years, the chances of you being diagnosed with a clinically significant cancer over the next couple of years is 5% or less. The next thing we need to understand is the causes of the heterogeneity in the delivery of the MRI results. Now, we talked about the benefits of MRI, saying the reduced numbers of patients undergoing a biopsy and the reduced diagnosis of indolent cancer are related to the rule-out ability, in other words, the negative predictive value, and the increased detection of clinically significant cancers and the greater detection of clinically significant diseases related to the rule inability, or in other words, the positive predictive value. So there must be a positive predictive value variance and there must be a negative predictive value variance. Now it turns out that the negative predictive value of prostate MRI is very high and there's very little variability. The positive predictive value variability is quite a lot. It's inconstant. So if you look at the negative predictive value in different centres, and this is in 8 of 10 centres in the UK, you can see the negative predictive value was 88%, but you'll see there's very little variability across the different centres. However, if you look at the positive predictive value, for targeted biopsies alone in 26 US centres, you'll see it varies from 25% to 75% and averages out at about 48%. This is the problem. So the positive predictive value is very variable and the negative predictive value is less variable. And so the positive predictive value variability and the negative predictive value variability depend on a number of factors. Could depend on the patient, depends on the imaging and the imagers, on the biopsy operators as well as the pathologists, and of course how well the team is working. So if you look on the negative side, you'll see the negative predictive value is high in this particular analysis and the variability is low. So if you look at the PI-RADS 1 and 2 cases, the variability is very low, and that's because only systematic biopsies have been performed in these patients. So it's difficult to get a systematic biopsy wrong because you're just putting random biopsies. And the prevalence is low. So we know the prevalence of clinically significant disease is low, and so we know that the prevalence correlates with negative predictive value. So if you've got a low prevalence, you're going to have a high negative predictive value and a low variability. However, on the positive predictive value side, we said that the positive predictive value, depending on what centers you're looking at, is anywhere between 30 to 50% on average. But you'll see that it depends on where you put the cutoff. So if you put a cutoff at 3 and above, that will be the detection rate, i.e. the variability. If you were to put 4 and above, that will be the variability. Also, within the categories themselves, so if you look at the variability within PI-RADS 4, it's much greater than in PI-RADS 5. Okay, because these are small lesions. In other words, there are issues with PI-RADS 4. And so this variability is related to the biopsy operators, right? So it's to do with the urologists, their targeting methods, and it's to do with the histopathologists, their expertise, and how you define clinically significant cancers. So we need to minimize these variations, both on the positive side and on the negative side. So what do we do about the imaging and the imagers? Well, 3 major points. Number 1, we need to quality check the imaging, and we need to say whether the image quality is good enough to rule in and rule out clinically significant cancers, whatever the definition you're using in your ADT. We need to train and educate radiologists who must attend theoretical and hands-on courses with CMEs. And we need to check on the performance of radiologists and how they are doing and whether they are working within MDTs. So many of you will go, this is certification. And it is. We do need to think about certifying radiologists. We also need to think about certifying urologists and pathologists. But we also need to think about accrediting MDTs. Because we know that MDTs improves the efficiency of pathways. We know that MDTs reduce the variations in diagnosis, and we know MDTs improve the adherence to guidelines. We know that our patients and our payers like the fact that we're working in MDTs. And of course, it's going to be integral to the accreditation process of MDTs. So accreditation of MDTs isn't just one metric, because we're looking at the coordination of several processes. So MDT accreditation has to look at all of these factors together, because it's evaluating the effectiveness of the teams. Remember, we need to quality assure our processes to deliver a safe and effective service. So we need to identify and measure those factors that are affecting variability, and we discussed some of those. That's the imaging and the imagers and the pathologists and the teamwork. We need to be able to control and assure the variability through processes such as monitoring, such as automation, such as monitoring the outputs of MDTs. So in other words, what is the inter and intra-center variability, the detection rates, etc. We need to train the participants of the MDTs with benchmarking. So radiologists, urologists, and pathologists. And this is certification. And finally, we'll need to develop performance measures of the diagnostic units. These are your MDTs. So what are the turnaround times? What are the complication rates? What are the patient satisfaction rates? So let's end there with my 5 golden rules for the successful delivery of the MRI pathway. Remember, not all men benefit from the comprehensive approach. We carefully need to assess risk using PSA density, before and after, and we need to tailor our biopsy strategies according to the clinical priorities of men. Remember, not all men are the same, but we do need to use the MRI as the roadmap to target patients. To target lesions, sorry, not patients. We need to accept that we will not find all cases, all clinically significant cancers immediately. That means we will have to have robust safety nets for negative cases avoiding a biopsy, and for positive cases that have a non-explanatory biopsy result, or even the positive case like a Pyrites 3 that doesn't undergo a biopsy. Finally, we do need to assure the quality of the diagnostic chain, in other words, through a robust and audited process of multidisciplinary working. I hope you found this useful, providing you with some good insights. Thank you very much for listening.